Hello everyone, welcome to the second session of Mind the Bleeps surgical series. Your first session was on the acute abdomen and an introduction to surgery as an F1. This is our second session, which will be on groin lumps. So as mentioned in the last session, we're 4 F2s who wish to give you a series of 16 lectures on how to essentially be a surgical F1. So we aim to keep these lectures quite clinical. We won't faff about with a lot of pathophysiology and surgical procedures, but rather what you guys will see when you're surgical F1s and how to manage common surgical presentations. So the general format of the presentation will be going through the diseases and the etiologies, the very brief anatomy and pathology of the different presentations. We'll go through how to clerk for the different surgical presentations you might see to please your seniors. We'll go through the investigations you should order as juniors and the investigations you might be asked to order and how to sort of get them through and accepted, for example, by radiology. And then the initial management, the acute management, you'll be expected to perform, and then the more sort of surgical senior management. And then we also want to talk a bit about complications of the surgical procedures, complications you might come across and be asked to initially sort out, and then we'll go through some cases. This is me, my name is Freya. I'm one of the 4 F2 doctors working in London. I have an interest in teaching, hence why we run this course. And the key learning points for our sessions, specifically this session, is identifying differential diagnoses of the different lumps you might see in the groin, key parts of the history and examination that you will be expected to identify and clerk, then understanding the surgical investigations that are required, and then we're going to practice some of these skills you're learning during the cases we'll see. So when we go through the cases, just keep in mind, as per last lecture, that you are the surgical F1 on and ask anything about them previously, and trying to sort of go through the clerking and what investigations you might want to order. So let's start out with some brief anatomy of the groin. So the groin is essentially this triangular anatomical space right by your hip bone. So it starts by the ASIS, the anterior superior iliac spine, then it goes inferior to the thigh, and then medial to the pubic tubercle. So the groin contains quite a few important structures that are involved in a lot of the pathologies that you'll see. It involves the inguinal ligament that runs from the ASIS to the pubic tubercle. It involves the inguinal canal. This is sort of a tube-like shape which runs parallel inferior to the inguinal ligament. Then you have the external iliac, and which becomes the femoral artery, which runs under the ligament. The psoas major is a muscle that runs from the vertebrae and attaches to the lateral trochanter of the femur. That also runs under the inguinal ligament. And then you have a bunch of lymph nodes around that area as well that could result in lymphadenopathy. So embryology always used to be a burden of my medical school life, but we won't go through too much embryology, but we will just briefly touch on it because it's quite important to understand some of the pathologies of the groin. So during development, at about week 12, the gonads reside in the around the L2 region of the lumbar spine, and they descend down to, in men, to the scrotum. And in order to do that, a part of the peritoneum creates an outpouching called the tunica, the processus vaginalis. And this pouching goes through the abdominal wall. For when the processus vaginalis protrudes through the abdominal wall, it creates a weakness. Usually, this weakness disappears throughout development, but sometimes it can persist, and that is the source of quite a lot of issues that we'll see in a minute. So the protrusion creates two rings. So when it protrudes through the innermost layer of the transversalis fascia, it creates the internal ring. And when it protrudes through the outermost layer, which is the external oblique aponeurosis, it creates the external ring. So we sort of have two openings of the abdominal wall. So when going through your surgical clerking, and especially in terms of lumps and bumps, you want to ask about the onset of the lump. So did it come on suddenly? Did they notice it suddenly, or has it been there for a while and then gotten bigger? How long has it been there? Very important to document whether they've had it before, whether it's a day's worth. Then you want to ask about pain. So is it a painless lump or a painful lump? You go through a usual Socrates history taking when you go through pain. So is the pain sudden? Is it severe? You can rate it out of 10. Does it radiate anywhere? So does it radiate up to the abdomen, down to the thigh, or into the scrotum? Do they have other associated systemic features? For example, fever, nausea and vomiting, rigors? Do they have any rashes? And this is very important, and particularly asking about rashes in the genital area as well. And then ask about long-term symptoms. So have they noticed any weight loss? Have they noticed any night sweats or long-term low-grade fevers? With any surgical procedure, especially general surgery, you want to ask whether they've opened their bowels. Have they been constipated? Then you want to ask about urinary symptoms. So any sort of urinary pathology, so whether it's a UTI or renal stones, can often be non-specific, and it can radiate into the groin as well, that pain. So ask whether they've had any LUT symptoms, so any problems passing urine, any dysuria, any hematuria. Then you want to ask about their past medical history. Always really important to document whether they've had previous surgery. And when it comes to the groin, always document whether their appendix is intact, whether they've had an appendicectomy in the past. Ask about any history of catheterization, and by catheterization I mean whether they've had a vascular catheterization. So have they had a recent angiogram, for example, where they've had a catheter into their femoral artery or femoral vascular system. Then you want to ask about sexual history. So do they have sex with men or women? Do they have protected sex? Have they had any histories of STIs? And then ask about immunosuppression. Do they have an active cancer, or are they taking immunosuppression for any other reason? And that is really important in terms of, for example, lymphadenopathy and infections. So for your examination, if the patient's acutely unwell, you want to always go through your ATE. If you're ever worried about how to examine a patient or how to document your examination, just always go through your ATE. It's very foolproof. When it comes to groin lumps, you always want to examine the patient standing up. This way you get a better view, and you can also get them to cough and examine the cough reflex. This is important in hernias because the increased intra-abdominal pressure will push the hernia out, and then you can assess whether it's a reducible lump. Then you want to very carefully examine where exactly this lump is. So where is it in relation to the pubic tubercle and the ASIS and the inguinal ligament? This can be quite difficult to palpate, especially in overweight patients. But the best way to do it is to try and palpate the femoral artery, and superior to the femoral artery, you should feel the inguinal ligament. So where is the lump in relation to the inguinal ligament, and can you feel the inguinal canal as well? Then you want to assess the size, shape, consistency, borders, and as mentioned, the reducibility of the lump, especially whether you can feel the upper border of the lump. So in hernias, because the upper border will be intra-abdominal, you will not be able to feel the upper border, whereas in, for example, a lymph node, you'll be able to feel an egg-shaped, either tender or rubbery round lump. Then you want to ask the patient to cough. This can be either standing up or lying down to see whether the lump protrudes. You can also feel the lump while the patient is coughing to feel whether it protrudes out as well. Then always remember to examine the genitalia. So any scrotal pathology, including infections and torsion, can radiate up to the abdomen as well. You also want to look for rashes and discharge, anything that could indicate that the patient has an infection of their genitalia. Then you want to examine the lymph nodes. So the lymph nodes may not be palpable in the inguinal region, but you want to examine the lymph nodes on both sides, and then an extensive lymph node examination of the other areas as well. In terms of investigation, you want to go through your usual bedside investigations. So always do a urine dipstick for any groin pathology, assess for infection or hematuria. In women of childbearing age, do a pregnancy test, always, always, always. And then obviously during this day and age, you want to do a COVID-19 swab, specifically to prepare them for theatre if that will be necessary, but also because it's a high risk to other patients on the ward. If they're acutely unwell, you can do a quick VBG to assess their electrolytes, their hemoglobin, their lactate, whether they're acidotic. And the lactate is very useful in abdominal pathology, specifically when it comes to hernias. If you're worried about a hernia being strangulated, we'll come on to what that means in a couple of slides, but a lactate will help guide that diagnosis. Then you want to do your routine bloods, so do a full blood count, your USNEs, LFTs, and a CRP, assess for any inflammatory markers. You want to send off urine cultures and blood cultures if you're worried about infection. If they have any groin pain, urine culture is probably useful, whether you're suspecting an infection or not. Then you want to do operative bloods in surgery. So always make sure they have a valid group and save. In a lot of trusts, this requires 2 group and saves within either 48 or 72 hours to make sure that's on the system, and do a clotting as well. If you notice any rashes or you're worried about STIs, do skin swabs or test for STIs specifically as well. So in terms of imaging, if you're a bit unsure what's going on, but the patient is constipated, they're in severe pain, they might have had an abdominal X-ray which shows distended loops of bowel, you want to do a CT abdomen and pelvis to assess for bowel obstruction. If you have a good history of bowel obstruction, no one will reject your CT abdomen pelvis request. If the lump is tender, it's in the hernial orifices, you're sort of not 100% sure what the etiology of the lump is, you can request an ultrasound to assess whether it's of vascular origin, whether it's a hernia. That's for non-acute presentations. Right, let's go through some cases. So you're the surgical F1 on take, and you are asked to see a 62-year-old male with a painful groin lump. This lump has lasted for 1 day. It was sudden onset of pain, and it's in the right side. When you palpate a painful, not painless, intermittent right-sided mass. Prior to this, he's had a mass for about 2 months, and it's been painless up until now, but suddenly it became very painful. His bowels have not opened and he has not passed flatus in the last day. He has a past medical history of COPD and he had an appendectomy when he was a young boy. This is a photo of the lump. As you can see, it's slightly erythematous, it's quite large. On examination, he is hemodynamically stable, but he does have a low-grade fever. His abdomen elsewhere is soft. When you can feel an irreducible, painful erythematous, elongated mass, which is superior to the inguinal ligament. You make him cough, but you can't feel a cough impulse. You check his scrotum, there are no masses, and on PR, he has an empty rectum. So you send off some bloods, you find that his inflammatory markers are raised, And because you're worried about this patient not having opened his bowels and him being in quite a lot of pain, you have an abdominal x-ray initially, and you see some dilated bowel loops. So your initial management whilst you're waiting for someone to answer your escalation requests is to stabilize the patient. So you want to manage his pain because he is in quite a lot of pain. So prescribe him his pain relief, start with your usual paracetamol. You might want to prescribe him some antiemetics if he's feeling nauseous as well. Prescribe him some fluids. Then you want to make sure you replace his electrolytes. So patients with constipation may have electrolyte derangements. Then you want to request an urgent CT abdomen pelvis and urgently refer to your surgical seniors as this patient is likely obstructed. You want to start some prophylactic antibiotics due to his raised inflammatory markers. Now, these are usually guided by either your trust guidelines or by senior preference. So make sure you check your trust guidelines before asking your seniors, just to have that little extra edge, and ask them whether they would like specific antibiotics. So this presentation is a common presentation of a strangulated inguinal hernia. Hernias are often incidental findings that are found on elective operations or on scans. Two types of hernias are found in the groin region. So you have your femoral hernias, which are more inferior than the inguinal hernias. These are more commonly seen in females because of their wider pelvic structure. And they also have a higher risk of strangulation due to the more narrow femoral canal. So if you diagnose femoral hernia, these probably will undergo a more speedy operation than inguinal hernia. Inguinal hernias are found in the they can be either indirect or direct in the inguinal canal. If they are strangulated, they are usually indirect because indirect hernias protrude through both the internal and the external ring, which means they have 2 points where they can be strangulated. Inguinal hernias are more common in men, and femoral hernias, as mentioned, are more common in women. Remember to always examine the scrotum. This is because inguinal hernias, whilst going through the inguinal canal, they follow the spermatic cord and they can actually protrude all the way down to the scrotum. So if you examine a patient with a scrotal lump, make sure you try and palpate for the upper border and see whether you can feel it and whether it's actually confined to the testicle or the scrotum, or whether it protrudes all the way up through the inguinal canal. So we have several levels of herniation. You have reducible hernias. When you examine the hernia, as mentioned, always try and reduce it. So push the hernia in, follow the course of the hernia and see whether you can push it in if the patient isn't in pain. Irreducible hernias can be either obstructed, which means that the lumen of the intestine is obstructed, but the blood supply is still intact. So the intestine is not necrosed. Then you have incarcerated hernias where adhesions have developed. And these are high risk of strangulation, which is when the blood supply is compromised. So any irreducible hernia requires urgent management. So the surgical management of hernias is obviously a hernia repair. Usually they are open mesh repairs, but if they're recurrent hernias, you want to laparoscopically repair them as well. The hernias can often protrude through the mesh and become recurrent, especially if there's increased intra-abdominal pressure, for example, due to obesity or COPD, which requires a lot of coughing from the patient. So we're not going to go into detail of the operation, but just to mention some of the complications that happen during intra-abdominal surgery in general, but you might also see particularly in hernia surgeries. So the intraoperative complications include bladder injury, bowel injury, and vascular injury. So just make sure you remember your anatomy. It's very simple. The bladder is quite close to the intestine. Very rare for the patient to experience any bladder injury, but make sure you monitor their urine output and make sure they don't have any hematuria or dysuria. Bowel injury, so make sure the patient is opening their bowels and is not in excessive pain after the surgery. And then vascular injury, if you're worried about any vascular injury, just check your routine bloods. Is their hemoglobin stable? Are they hemodynamically stable? You can do a peripheral vascular assessment, make sure you feel the peripheral pulses. Post-operatively, it's quite common to find post-operative complications after general surgery. The patient might have a hematoma, which you may be able to palpate or even see. Again, you want to check the hemoglobin, check the hemodynamically stable. You want to check the hematoma doesn't compromise any of the vascular supply to the legs. Assess for urinary retention. So this is independent of any bladder injury, but patients can quite commonly, after being catheterized or after being on general anesthetic, or just having a lot of insult to their abdomen, experience urinary retention. So make sure you examine their output, measure their output, and if in doubt, do a bladder scan and catheterize if you think that's necessary. In a bladder scan, it's quite difficult to know when to catheterize or not. I would say if the patient's in discomfort and has sort of around 500 plus milliliters in their bladder, it's probably best to catheterize the patient and let the seniors make a decision as to when to trial without a catheter. Wound infection is quite common, so make sure you assess the wound if they're complaining of pain excessively or whether they're showing signs of infection. And then a recurrence of hernia is also quite common, unfortunately. So let's go into the next case. You are asked to see a 56-year-old male with a painless groin lump. This gentleman was admitted with fresh PR bleeding initially. He's now complaining of a solitary, firm, rubbery, non-tender, egg-shaped, left-sided groin lump. It measures about 4.2 centimeters, according to the patient. He's also experienced some weight loss, about 6 kilos in the last month, and he's experiencing some bowel symptoms, including tenesmus, diarrhea, and of course, the PR bleeding. He doesn't have any background history. He's been fit and well previously. Under assessment, the patient is hemodynamically stable. He is, however, a bit cachexic. You can kind of see the weight loss and its effects. And in terms of further examinations you want to do for this patient, so when you examine this lump and it's rubbery and painless, you want to immediately think of lymphadenopathy. So it's very important to examine the rest of the lymph nodes, especially on the other side, and just do a full lymph node examination. This patient was also complaining of PR bleeding. So you want to do a PR examination to assess for any current bleeding. Because he has a lymph node in the groin, you also want to assess the scrotum and you want to assess the perianal area and see if you can identify any sources of infection or malignancy. So you do some routine bloods for him. His hemoglobin is 75. This is after 1 unit of red blood cells, so he's had quite a lot of blood loss. It might be an ongoing anemia as well. His inflammatory markers are normal, so this sort of makes you think that potentially the lymphadenopathy is not infection. The other thing to mention is that a non-tender lymph node is rarely or less commonly infection, and it does make your suspicions point towards malignancy rather than inflammatory cause. So you do some further investigations. Because he's quite anemic, you want to send off iron studies. He's a surgical patient, so always send off your clotting and your group and safe. Send off a blood film because of the anemia, and then because of the lymphadenopathy, you probably want to send off some tumour markers. Now, he has this PR bleeding, which hasn't been assessed by a senior yet. You probably want to examine him a little bit further. So whether you want to do a flexi-sig, colonoscopy, or an anerectoscopy is probably a senior preference, but you want to see where the PR bleeding is coming from. Now, you do a flexi-sig with the help of your senior, and unfortunately, you identify an anal malignancy, an anal mass, which is profusely bleeding. So when you identify a colorectal malignancy, you always want to order a staging CT chest abdo-pelvis as well. As mentioned, any rubbery, non-tender solitary lymph node is always suspicious of malignancy. Case 3. You are asked to see a patient, 72-year-old female with a tender groin lump. She was initially admitted with chest pain. She went on to have a coronary angiogram through her femoral artery yesterday. Since then, she's had a one-day history of a mildly tender erythematous soft lump in the right side of her groin. You examine her and she is hemodynamically stable. She's slightly febrile. You notice a right-sided pulsatile mass about 5 to 6 centimeters below the inguinal ligament. The superficial skin is intact and you don't notice any excessive erythema or any discharge from this lump. You do your bedside test. Your analysis shows no abnormal findings. Your routine bloods are normal, and you then request an ultrasound Doppler, which shows a femoral artery pseudoaneurysm. The reason why we choose an ultrasound Doppler in this case is because the lump is pulsatile. So this is quite uncommon to find a pulsatile lump in the groin. With any pulsatile lump, you want to immediately think of a vascular cause. Now, this patient has very recently had an insult to her femoral artery through the cardiac angiogram. So you immediately have to think that this might be a femoral pseudoaneurysm. So femoral pseudoaneurysms are usually iatrogenic. They come from catheterization. They can also be created through IV drug use, which is quite common. Drug users may use the femoral artery when their antecubital arteries or their arm arteries or veins are defect, and then they use their femoral vein and puncture the femoral artery, which creates a femoral pseudoaneurysm. Trauma, whether it's blunt trauma to the groin after, for example, road traffic accidents, can cause a femoral pseudoaneurysm as well. When you find a vascular cause of a lump, it's really important to examine the lower limb, and you want to clearly document this as well, especially before any further intervention. So make sure you do a full vascular examination, examine the popliteal artery and the peripheral foot arteries as well, and do a neurological examination as well. You want to send off your routine bloods, do a clotting and a group and save, and especially monitor the hemoglobin. Gold standard femoral pseudoaneurysms is a duplex ultrasound. If you have a pulsatile mass, it's definitely warranted to ask for an ultrasound. Pseudoaneurysm can get infected. This is a surgical emergency. An infected aneurysm of the artery can lead to clot formation, and it can obviously lead to a spread of infection systemically. So this requires an urgent ultrasound. Otherwise, pseudoaneurysms can be managed with a watch and wait approach. So if they're small, around 2 centimeters or less, and they're asymptomatic, you might do regular ultrasounds as an outpatient and observe, and the patient may find that the pseudoaneurysm actually resolves by itself. If the aneurysm is large or symptomatic or infected, as you can see in the photo, they'll often have a puncture with a discharge or even bleeding. You want to do an urgent ultrasound guided compression or thrombin injection to manage this pseudoaneurysm. If it's really large, you might also surgically manage it. So this will be a referral to the vascular surgeons. So case 4. You are asked to see a 33-year-old gentleman who's febrile and has a tender groin lump. He is admitted with a fever and right lower quadrant pain for about 10 days. His pain restricts his movement, including walking. He's been limping for the last 10 days. He's also noticed 5 kilos of weight loss in the last 2 weeks, and night sweats in addition. He has no history of any trauma, any surgery, or IV drug use. The only background he has is type 1 diabetes mellitus, which is fairly poorly controlled in this man. So you examine him. He is hemodynamically stable and fairly well, but is febrile, 38.1. You examine the right groin lump. You find that it's below the inguinal ligament after careful examination. You also see that his hip is passively flexed for comfort, and when you try to extend it, he's in a lot of pain. So you want to now do a further, quite detailed examination of the hip joint. This is because this patient is presenting with sort of fixed flexion and a fairly painful inflammatory lump of the groin. So you want to do a full hip examination of both sides. You also want to do a lumbar spine and knee examination, to always examine the joint below and above. And then you want to do a lower limb neurovascular examination and make sure you document these very clearly. So in your examination, you find that he has a limited range of motion of the right hip, and he has particular pain on hip extension, hence why he's keeping it flexed. You order some bedside tests. So his urinalysis comes back as normal. His white cell count is very raised at 23, as is his CRP, as at 312. His U's are normal, and his bloods and urine cultures are pending, and obviously don't come back until about 3 days. You order a chest X-ray, which shows no abnormal features, and you also order a hip X-ray because this patient might have a fractured hip, but this is also completely normal. So far we've found this patient with a tender right groin lump. He has ongoing fever, night sweats, weight loss, reduced range of motion, and raised inflammatory markers. Specifically, white cells are 23, which is very high. So there's obviously an infection going on, and you want to start some empirical antibiotics while we're waiting cultures. He's quite unwell with his infection, so you want to start some broad spectrum antibiotics. Often tazocin is used. This is a pyrexia of unknown source, but it is fairly likely to be somewhere in the hip. This therefore warrants a CT abdomen and pelvis. So you get your CT abdomen and pelvis, and you find that this patient has a large psoas abscess. Psoas abscesses are quite rare. They're usually seen in immunocompromised patients with diabetes or CKD, or patients with Crohn's disease or any intra-abdominal inflammatory process going on. The reason why his white cells are so high is because when you have a confined abscess, a confined space with pus forming, the white cells can usually go up very high. So whenever you see a really high white cell, think of potentially abscess formation or lymphatic malignancies as well. So Psoas abscesses are emergencies. They can cause quite unwell patients, and they require drainage. So this is either percutaneous or open drainage. They'll also be treated with quite intense antibiotics. You want to target these antibiotics to the cultures that come back, and you also want to culture the abscess fluid. So in literature, it's Psoas abscess is described as a triad of fever, flank pain, and limited range of motion of the hip. So this is unfortunately rarely seen, as with most of the descriptions in literature, but they will often have a fixed flexion of the hip because of the pain of extension. So the psoas muscle is one of your main hip extenders, and therefore the extensions of it, sorry, the hip flexors, and therefore extension will be quite painful for the patient. As mentioned, it's seen in immunocompromised patients, patients with diabetes, CKD, HIV, and any previous surgery, and you want to treat them with the antibiotics and drainage. So just to mention the scrotum, it's very important to to examine the genitalia in any groin lump or groin pain, because many of the testicular pathologies, such as hydroceles, varicoceles, tumours and particular torsion, can cause radiation of pain up to the groin. The other reason is that inguinal hernias, as mentioned, can protrude down to the scrotum, and therefore if the patient has a painful obstructed hernia but you can't really feel a groin lump, you want to examine the scrotum as well. Be very wary of testicular torsion. It causes necrosis of the testicle, and it's a really important diagnosis not to miss. So, red flags, when to be worried and when to escalate. The patient has a very painful swelling and they also look septic or very, very poorly. You always want to escalate that. An irreducible painful swelling that you think is probably of hernial origin is a surgical emergency and needs to be escalated immediately. Any pulsatile swelling that will indicate a vascular source of the lump, that needs to be escalated to the vascular surgeons. And any recent interventions, whether that's a recent operation or catheterization or any other insult to the groin area, is a red flag. So, key points for groin lumps. A thorough examination and documentation of this is key. So remember to properly describe the lump, whether you can feel the upper border, whether it's reducible, whether it's painful or not, and the consistency of it. Is it soft? Is it rubbery? And also remember to examine the lymphadenopathy, or the lymph nodes widespread, and check your urinalysis and examine the scrotum as well. If you think the cause is vascular, always do a peripheral vascular examination. Examine the joint in full if you think there's any pathology to the surrounding joint areas, and examine the joint above and below. Don't forget other non-surgical causes. Even though you're a surgical F1, you'll get a lot of referrals that aren't surgical. It would be very helpful to properly differentiate between surgical causes, not just because your seniors will be happy that they have one less patient on their patient list, but also because it targets appropriate management for the patient. And some of the other causes, such as Psoas abscess or lymphadenopathy, really need to be thoroughly investigated. Remember your post-op complications. Examining a patient post-op is quite different from pre-op. If you're unsure what's going on, just do your full ATE. Ask them if they've opened their bowels. Check whether they're septic, have any abnormalities of their bloods. Are their electrolytes okay? Can you manage them with fluids and pain relief initially? And then whether they have appropriate antibiotics prescribed if they have an infectious process going on. Okay, that completes the lecture on groin lumps. So our next lecture in a week's time will be on appendicitis. We, as mentioned, will run 16 total free surgical webinars as part of Mind the Bleep. We hope that this is useful. We try to keep it very clinical and try to keep it aimed at F1s and how to sort of manage things initially on the ward and when you're by yourself. It is very daunting to start out, especially in surgery, as I don't think we learn too much about how to manage surgical complications and surgical presentations as F1s on our own on the ward. We would be very grateful for your feedback, so you can follow this QR code here. You'll get a certificate for participation when you fill out the feedback form. Visit Mind the Bleep's website for the webinar recording to get a recording of this lecture, and we also provide written content of the lectures as well. And if you don't want to ask any questions now, please don't hesitate to send us an email on webinars@mindthebleep.com. We'll be very happy to answer any questions you have, whether that's about the specific lectures or whether it's about a career in surgery or life as an F1. So I hope you will enjoy this lecture. We will keep this up on the screen for a little while longer.